Good morning from the annual meeting in San Diego. We're pleased to be here with Dr. Sam Garg. Good morning, Sam. Thanks for being with us.
Thank you.
Sam, we've heard a lot on this program and at many other meetings about scleral fixation techniques of IOLs. And there's been particularly a robust new armamentarium of techniques that have come out and been presented. And I think that at some of the meetings, we tend to see the best cases and the best outcomes. I understand you have a session at this meeting that's talking about the complications and how to approach them and how to fix them. So can you talk us through that? What are some of the complications that we can encounter with scleral fixated lenses?
Sure. Great question. So we always do, when a technique comes out, talk about the positives. And the techniques I'm going to talk about, specifically is fixation of an IOL with Gore-Tex, or some of the newer scleral fixated techniques such as glued or the Yamane technique into scleral haptic fixation. So there's no technique that's without risk. One thing I've been doing recently is talking to patients about the off-label nature of this procedure, because as we do these things longer, we're going to see potential complications that come down the line. So in my standard consent now, I've put it in a little note there that says, telling the patient that this is a off-label technique, and we can't really predict what's going to happen in 5 or 10 years. So some of the things we've been seeing recently, with Gore-Tex, there's been some reports of erosions or maybe infections. Certainly with the intrascleral haptic fixation, you can get erosion of the haptic or dislocation of the haptic. It is a 2-point fixation, so you can get tilt. And then along with all the other common complications with IOL exchange, infection, retinal detachment, CME, things of that nature.
I know that the finding that you are presenting regarding Gore-Tex is interesting, because for a time there had been some back and forth and some debate about what type of suture material, whether Prolene or Gore-Tex or others, would be of benefit. What kind of suture technique do you usually, or suture material do you usually use for this?
So I don't think there's any perfect suture. There's many people who are big believers in Gore-Tex. Gore-Tex, it specifically says on the package not for use in the eye, but I think that's okay. I typically use when I am suturing a lens, I'll typically use Prolene, but I've really gravitated more towards the sutureless sort of fixation techniques for a couple reasons. I think that you can use smaller lenses that fold through a smaller incision, and so that you don't have to worry about this big, large PMMA lens. Now there are cases for that. The other thing is picking the right lens, and my lens of choice for this technique, either the glued or the Yamane, is the CT Lucia by Zeiss. The reason for that is the haptic is made of PVDF, and it's really, really resilient to damage. And when you do these techniques, there's quite a bit of intraocular gymnastics, if you will, and keeping that haptic straight is important.
Speaking of gymnastics, I'm glad that you brought that up. I always have patients that come in after standard cataract surgery and are wondering about what type of physical limitations they may have. Do you think that that's different for a standard cataract uncomplicated surgery versus a scleral fixated IOL? Do patients have to take more specific restrictions in terms of activity?
Yeah, I mean, typically I warn them. I'm a little more cautious with them. Certainly no eye rubbing for several weeks. Because there's now a potential pathway to the vitreous, I tell them to avoid any kind of ocean or pool swimming or hot tubs for 3 to 4 weeks. But in general, it's not that different. The beauty of these techniques is they're relatively minimally invasive compared to our previous large incision scleral sutured IOLs.
I wonder, Sam, it seems like scleral sutured and scleral glued and other means of fixation of IOLs is sort of a technique that ophthalmologists have developed on their own in the absence of a sort of commercially available way to do this. Do you think that we're moving in that direction as more and more ophthalmologists are performing this technique? Do you think that some of the bigger players, the lens manufacturers, will come in with commercially available technology that will assist in this type of procedure?
Yeah, that's a great question. I don't know, because in order to bring something to market like that, there would have to be a trial. And to do a trial on something like this is probably fairly difficult. There are many lenses in development to help with some of the issues that we have with dislocated lenses. There's some novel fixated lenses on the capsular rhexis to, for instance, to decrease the incidence of dysphotopsia. So people are looking at things like that may be a little easier to determine the endpoints. I'm not sure if anyone's going to jump in with 2 feet and come up with a specific indication for this kind of fixation.
That's a good point, Sam. Well, this has been a terrific discussion this morning. Thank you so much for being with us, and thank you to our live audience. We appreciate your support. Thanks.
Thank you so much.